Hi students, I'm going to do a lecture on the musculoskeletal system. I actually was a coder for 10 years and this was one of my specialties and I did like it because it was always challenging. Okay, one thing that you will like is that once you figure out the layout of the musculoskeletal system, it starts with the anatomic site. So it actually starts with the top of the head and it works its way down to your toes. So, and then it's by service. So it'll start off with excision, incision, and so forth. So this is used extensively by the orthopedic surgeon. Some of the codes can be used by a variety of physicians. So it's not just orthopedic. So let's go ahead and keep going here. All right. So the most common things that you will see in this chapter are fracture dislocation. You will have general subheadings. I will talk about arthroscopic procedures and cast and strappings. Okay, let's start off with fractures. The first thing you want to know is the site of that fracture or dislocation. Okay, is it the femur? Is it the radius? Is it the ulna? Okay, you want to figure out where that fracture occurred. The second part is type of treatment. Is it open? When we're talking open, that means they're making an incision into the body to treat that fracture. Closed means that they are literally going to do a closed reduction or manipulation to put those bones back aligned. Okay? They're not making an incision. They're, again, taking their hands or whatever they use machines to get those two bones back in line, no incision. If a manipulation is performed, it will be documented. Then you want to know, was there traction used? If so, what type? You will see traction a lot of times with a hip fracture that they put the patient in traction. Percutaneous fixation, that is going to be usually with pins. So let's say they did a number on their ankle. They broke their ankle in a couple of places and they did percutaneous fixation. Sometimes you'll see those pins actually sticking out of the fracture. Internal fixation, make sure that this is not included in the code description. Okay. Internal fixation means that they're putting pins inside the body. So they put pins inside, let's say again, the ankle. They put pins inside of that fracture and then they close it up. Sometimes those pins may stay in there forever. And sometimes they'll say after 6 months of healing, they'll go in, make an incision, and pull them out. External fixation, that would be like a brace, anything to keep it in place. It's on the outside of the body. And then did documentation support skin closure? And what type of anesthesia was used? Okay, let's move on. Fracture treatment. Open. Okay, what does this mean? Surgically open to view or remotely open to place a nail across the fracture. So you will see the wording open reduction internal fixation. Once again, that means they made an incision to go in and repair that fracture. Closed treatment, the fracture site is not exposed. Percutaneous is neither open or closed. You have fixation devices such as pins. These are placed across the fracture site, as I stated before. And one thing, treatment terms do not be confused with type of fracture. Okay, open fracture, that is where the bone protrudes out of the skin. Okay, the bone penetrates the skin. So a closed fracture, the bone does not penetrate the skin. You don't see the bone coming out of the skin. Now you can have a closed fracture, okay, where the bone's not coming out of the skin, but have an open reduction internal fixation. Okay? That means they have to make an incision to get in there to close that fracture. So make sure you know the difference. You can have open fracture, closed fractures. You can have open treatment, closed treatment. You can have a closed fracture and an open treatment. Okay, so again, make sure you read the wording of your operative report. Okay, fracture treatment 2. The type of treatment depends on the type and severity of the fracture. Complicated in a code descriptor may indicate, okay, this is important, so excessive hemorrhage, infection, possibly prolonged physician work, difficulty in reaching the site, or death of the site, right? Let's talk about, make sure you know a couple of different things here. Um, what type of fracture would most likely be used for a green stick fracture? Read up on all your fractures, okay? A lot of them, green stick, what does it mean? Is it closed? Is it open? Okay, what type of fracture? But the treatment for that probably would be a closed procedure. An open fracture, of course, it's going to be an open procedure because the bone is, once again, protruding outside of the skin. All right, let's move on. Okay, traction. Right here is a perfect example. You have the application of pulling force to bring that bone into alignment, hold it there, and that's called traction. So you see that they're doing that with the bone. Like I stated before, you will see this a lot also with the hip. Skeletal, right here, force, distraction force applied to an internal device, wire, pin, screw, or clamp is inserted to the bone. Okay, with that, there are two types of traction. You have skeletal and skin. With skeletal, you have the internal devices such as your pins, your screws, or wires. They're inserted directly into that bone through the skin. The protruding end attaches to that traction vite, uses weights, pulleys to hold that bone in place. Once again, you're going to see that they show you a picture here of the arm or elbow. You'll see this a lot in the hip too, especially with older people because they a lot of times cannot go under anesthetic. Okay, skin traction, just the force by means of adhesion to skin. Manipulation, you will see this in wording a lot in the musculoskeletal. You use force to return a fractured bone to normal alignment. So that fracture repair codes are often divided based on whether manipulation was used or not. Okay, otherwise known as reduction. Manipulation means a fracture has been reduced. Okay, manipulation is a reduction, so keep that in mind. Okay, fracture term. Fractures are described by a physician in terms of the direction of the fracture. Was it horizontal, vertical, oblique, spiral? The direction, the degree, angulation, the most distal fragment. When the fracture results in more than two fragments, it's commuted. Okay, so keep that in mind. That's another good term to know. Okay, dislocation. The bone is displaced from the normal joint position. Different from a fracture. Fracture is when the bone breaks. Okay, dislocation is different. Okay, keep that in mind. Fracture, the bone's broken. Where dislocation, the bone is displaced from the joint, but not broken. Okay, dislocation, how it's treated. You move the bone back into that correct position. Okay, so we get into the beginning of our musculoskeletal, 2100 to 2999. It begins with wound exploration. Okay, one thing, difference between your integumentary codes and musculoskeletal incision codes, musculoskeletal is more in depth. It is used when underlying bone or muscle is involved, where integumentary is going to be your top layers. So keep in mind with that, integumentary is going to be more superficial, where musculoskeletal is going to be more underlying. Okay, so a lot of these we get into location. With these wound exploration, it just includes these different headings. All right, let's go to biopsy. One thing to remember, they are located in the excision subheading, and these biopsies are for bone and muscle. Okay, if you want different biopsies or more superficial, you're going to go into the integumentary system. So you want to know the type of biopsy, bone or muscle, how far it went, and usually the method. Okay, so a couple of different things. They can be percutaneous needle, means they take a needle in, pull whatever they need out, or excisional, where they actually go in there and scrape some bone out. If a lesion is excised and biopsied, only the lesion can be billed. Okay, so what I'm saying here, the excision can be billed. So if they go in there, they take the lesion out, they biopsy it. You're not going to code the excision and the biopsy both. You only code the excision. Okay, this is a good example of unbundling if you would code both. So if the biopsy is taken on one day and based on the results, the next day an excision was performed, or even later on that day, modifier 58 may be appropriate, which means stage procedure, saying, yep, we knew the possible we'd have to go back in. That way they get paid for both, because it's going to be two different surgery times, two different preps, that type of thing. All right, let's keep moving here. Okay, so then we're going to go into removal, the next general subheading. Under here, we're going to have codes for injections, aspirations, insertions, applications, removal, adjustments. So the first thing here, we have sinus tract injection procedures. Nothing really as it states here. Removal, this could be foreign bodies lodged in muscle or tendon sheath. Integumentary removal codes are for removal from the skin. Once again, they're going to be in a different area. They're going to be in the integumentary system. So don't overlap the integumentary and musculoskeletal. As long as you understand that the muscle is going to be more complex and the musculoskeletal, just as it states, integumentary is going to be more skin. Okay, so we have arthrocentesis, which is injection and or aspiration of a joint. The biggest thing here when coding is these three codes, okay? They don't use ultrasound guidance, but you need to know the difference between these, because you have minor, you have intermediate, and then you have the major. Just make sure if you're doing a shoulder joint, you know that's going to be a major. And these all state more information with them. Arthrocentesis, sometimes you're going to have that HCPCS code with them to report that drug separately with the J code. Okay, we get into our internal fixation. Another subheading. Just kind of look at the picture here. External fixation, we have uniplane, which is pins or wires in one plane. Multi, this is complex adjustment. Code fracture treatment and external fixation. Move on here. Grafts and implants used to report harvesting through separate incision of the bone, cartilage, the fascia, tissue. So with graft procedures, okay, with the harvesting of the bone, a lot of times this is through an incision. Separate from that, used used for the graft itself to implant that graft. So you need to harvest whatever you need, the bone, cartilage, etc. And then you're going to have to implant that graft. So the graft material is used in different repair procedures. So let's say a tibial fracture fails to heal. The surgeon at that point decides to use bone grafting. So what you want to look at, where is that material obtained? From a patient or was there a donor? Okay, so here we have different grafting material. Upper thigh, where it's the thickest, we have grafting material. Then we do not code these separately. Okay, again, one code, right? Um, when you're in the musculoskeletal section, always look for that in parentheses where it says separate code. Okay. If you have a code that says separate code and there's a bigger procedure being done, you do not use that separate code procedure. That means those separate codes are usually a part of something bigger. Okay. So you don't code them both. Like I said, if you do, then that would be unbundling. So always watch out for those separate codes that are in parentheses. It will say separate code. Okay, with this bone marrow aspiration, it's used for lumbar spinal fusion. Report in addition to primary procedure. Okay, you can just read through these. There isn't anything I really want to touch base on here. Um, Repair is by location for the spine. You're going to start with cervical, then you're going to go to thoracic, then lumbar, sacral, down to the coccyx. Open incision and drainage of deep abscess of spine. Once again, that's divided by location. Arthrodesis, okay, it's fixation of the joint. Fixation with pins, wires, rods, often performed with other procedures. So you're going to use if it's if it's okay. Let's start over. Start over here. If it is used with a fracture repair, and then you have arthrodesis, you're going to put a 51 on that arthrodesis for multiple procedure. So keep that in mind. Arthrodesis is the fixation of that joint, just as I stated, and always use that 51 modifier if it's with another procedure. Spinal instrumentation. This is going to be segmental or non-segmental. They do this a lot, of course, with back surgeries. The big thing with spine procedures, you are going to see a lot of 51 modifiers on those added procedures. Okay, so here we go. I told you how, like, once we get into, now if we're getting into the head, we're moving down to the toes. It always starts off, we have the head first. It goes incision, excision, manipulation. You're going to see this for the subheadings. Cast and strapping. Replacement procedure, initial placement stabilized without additional restorative treatment. The initial fracture treatment, this is very important, includes placement and removal of first cast. Okay? Initial, so you don't add that extra casting code. When you do act, let's say a patient went in, got their cast wet, got something stuck in the cast, they remove it, have to add a new cast, then you can code it. Okay? You can't, for a general casting of the, let's say a break of the ankle, when they put it on, it goes with that closed reduction or open reduction, whatever they did, whatever the procedure was. When they take it off, all included in that initial code. You don't add an extra casting code. You only do if something would happen. Let's say a young kid gets a ruler stuck in the cast because they're trying to itch. They have to remove it, put a new one on, then at that point they can charge. Okay, just kind of what I was talking about here, casting and strapping. Endoscopy, arthroscopy. Okay, surgical, this is very important. Surgical arthroscopy always includes diagnostic arthroscopy. Okay, so here's an example. You're having diagnostic knee arthroscopy done. Okay, they're going to go in there, check out to see what's wrong with your knee. Okay, so you have the arthroscopy of the knee done. They get in there and say, you know what, we need to fix your meniscus. You tore your meniscus. So they ended up doing a meniscectomy. You no longer code the diagnostic arthroscopy because it's included in the surgical arthroscopy. Okay? Now, if they did more than the meniscectomy, let's say they also did the ACL at that time, you can code the ACL meniscectomy, probably a -51 on the meniscectomy. All right, let's keep moving. And that is the conclusion of chapter 15. Hopefully this lecture helped you out. If you have any more questions, please reach out.